All right, all right. Good evening, everyone. Depends on where you're watching from. Good morning, good afternoon. How is everyone doing? Welcome back again to this channel, to the Everything Public Health. Used to be Everything Chess channel. However, there's going to be a change and we're making it Everything Public Health, right? So my name is Ruben Ojo, for those who are watching for the very first time. And of course, if you've been a part of this journey from the very beginning, I want to say thank you and welcome back. How are you guys doing? And hope everything's moving on smoothly. So again, like I promised in one of the videos we made for the chess license exam, that we're probably going to have a discussion around some sensitive public health topics. So this is going to be the very first one that we're going to be doing on one of those topics. And of course, I also want to add that if you particularly have a topic that you would like us to talk about, you can reach out to me. My email is somewhere there. If it's not there, you can send me, you can comment, and I will probably shoot you that email. All right. So again, this is expected to be a 35 minutes, 40 minutes presentation. So, like always, you have a question, you have a contribution, the comment section is wide open. Pop in there and drop what you have. All right. So tonight we will be looking at social determinants of health, and of course the acronym for that is SDOH. So you're probably going to be seeing a lot of SDOH and not social determinants of health in the course of this presentation, if that is fine. All right. So let's move on to the outline. All right, so we're probably going to be looking at these 6 basic things or themes in the course of this presentation for social determinants of health. The first one is going to be the introduction, definitions, summary, a few CDC extractions here and there, and of course, what are the components of SDOH? What makes up SDOH? All right, so what is the level of interaction between these components? All right, so are they independent components or they are dependent components? And I think that's something we don't talk enough about in the public health world. All right, so what are the context of this SDOH? And especially for this context, it's gonna be specifically for the chess candidates. Some of the questions you would expect in the exam, how you expect the questions to be framed, the manner in which you expect the questions to be asked, because no question is just going to ask you, hey, what are the components of SDOH? That's not going to happen, right? It's not going to happen. So again, applications of SDOH and recommendations. I believe this recommendation is going to come along also in the form of conclusion. All right, so it might be one of the two. I'm not sure of what we have on the slide. Okay, so summary. The totality of the summary on SDOH is based on extractions from CDC and most likely extractions from WHO, because those are in reality the 2 major international health bodies that we have. So we're trying to take on something that is applicable from America to Asia to Africa to Europe and the likes of those places. So social determinants of health are non-medical factors that influences health. All right, They are non-medical factors that influences health. So what does that mean? It means that when we talk about SDOH, they are not, number one, clinical in nature. It has nothing to do with how clinical they are. It has nothing to do with laboratory terms. It has nothing to do with medical terms. They are non-medical, all right? If we're to be talking about cancer right now, we would say they are non-intrusive processes, all right? But we're not talking about cancer, all right? But in reality, when we say non-intrusive process, it means non-penetrating processes. So it's non-medical. It has nothing to do with the clinical aspect of health. Actually, it has nothing to do with diseases, all right? It has nothing to do with complications from diabetes and all of those things. It's non-medical, all right? So it's usually defined by CDC as the conditions in which people are born, they live, they grow, and they age. So all the components of SDOH combined together simply attest to the fact that this is the condition in which people are born. This is the environment in which they live. This is the growing or living conditions they grew up with. And, you know, as we all know in public health, age is a major factor that determines health. You do not expect a 16-year-old, the bone system, the articulations and all that to be the same as an elderly person. We can have more elderly people with arthritis, but it becomes an health anomaly if we have 16-year-olds with arthritis, all right? So you can factor in age. So all of those things are, they are a component of SDOH, and they determine the extent to the quality of the health of people, all right? So also, SDOH is a combination of forces, systems that shapes the conditions of daily life. So remember, we said it's non-medical. So now we're starting to talk about what are the systems in place. It can be governmental systems. It can be the social system. It can be the infrastructure around you. It can be the health accessibility component of it. It can really be a lot of things, but those things are non-medical in nature. They are non-medical in nature, all right? They are non-medical in nature. So also, SDOH, the forces might include, like we said, economic policies, social norms, development, racism, redlining, and all of those things. And before we go on, let me say this. There is something I believe in so much, especially in America, that I believe should be included as a major component whenever we talk about SDOH, and that is zip code. Zip code in the United States is as powerful and a much more determining factor in what a certain people have access to, in how a certain region is being treated. And basically that's what we're discussing here, right? SDOH, non-medical factor. Zip codes, they are non-medical factors. So SDOH are also referred to as the upstream factors. So a quick assignment to you, if you are listening, what is the difference between upstream factors and downstream factors of health? That's something I want you guys to go check out on your own, okay? So I will be waiting to hear that response, maybe in the comment section. You know, you probably just learn on your own. but then just keep it in mind. All right. Why social determinants of health? Now, let me give a quick perspective into the slide. I come from a region, and I'm African, proudly Nigerian. I come from a region where public health doesn't quite have as much value as it does in the developed nations. I'm going to repeat that. Public health doesn't necessarily hold much value as it does here in the United States and in Europe and other places. Doesn't mean it's non-existent. However, the existence is questionable. The attention we give to it is questionable. So places like Africa and the developing world would care less about social determinants of health. They are all about the medical aspect. And that is a turning factor. That is a turning point in determining the health of a people, in determining the health of a nation. For example, it's so difficult, at least from my experience, and I practiced public health for a couple of years in Nigeria before moving, right? So I have an idea of what I'm talking about. We do not think access to good water and quality food and good infrastructure affects health the way diseases do. And that's just the truth. All right. Our health system is not designed that way. Our health system is not designed that we think that a disease will kill you faster than economic instability, than access to quality healthcare, than access to infrastructures and the likes of those things. So just putting that out there. So SDOH interferes and influences the outcome of health and development. And it's that simple, all right? The outcome of the health of a priority population or a target population in large part is determined by the contributions of the SDOH components, by the interaction of the SDOH and the people, all right? So it is a two-way system. It is a two-way system, all right? So, and I dare to say in economic terms, it is honestly demand and supply. And we talk about that in one of the components. So health is generally influenced at 3 distinctive levels. Now, those levels are pretty easy. And I've said this before, for those who are taking the CHESS exam, one of the first things you honestly need to understand is public health happens at 3 levels. At the individual level, at the interpersonal level, and of course, at the community level. This goes a long way to help the way you view the CHESS exam, the way you view the CHESS curriculum, all right? It helps you a lot. So health is influenced at the individual level. And a good example of that is, let's pick on diabetes. At the individual level, it's important that you understand personally the basics of diabetes, the things that can cause diabetes, all right? The risk factors for diabetes. That can happen at an individual level. You can have an understanding of that for yourself, all right? At the interpersonal level, it's a two-way communication, like in the case of counseling. Now, sometimes you just live in a place or your living condition in terms of finances just doesn't favor you to have a counseling section. Why? How do you pay for it? All right. Do you have access to a good health counselor? Do you have access to good health education? that goes on an interpersonal level. And of course, on a community level, which we would regard as the biggest level in which health is influenced. Why? Because we have more people, there is a broader scope in terms of population, there is more focus, more resources that can be dedicated to influencing health at a community level. So generally, you won't expect that the same level of attention that is given to someone at an individual level is the same level of attention that is given to the community level. That's absolutely impossible. That's absolutely impossible. All right. Moving on. Research shows that social determinants of health can be more important than the healthcare or the lifestyle choices. And why is that? Why do we think that SDOH can be more important? Because of the level of interaction they have. They are upstream factors, all right? So it's a top to bottom approach. If the SDOH factors are insufficient, or they are inadequate, or they are not up to standard, it technically affects everything down the health chain. So that is important. That is super important. All right. So addressing SDOH, I made a mistake right there, appropriately is fundamental for improving health and reducing long-standing inequities in health. All right. And I think that is self-explanatory. Moving on. So, what are the categories of SDOH? What are the components of SDOH? And just before we go on the components, and I know you can see them on the screen, it is important to mention that these components have been modified over time. Let's bear that in mind. They've been modified over time to accommodate and to give a ground meaning to all of the factors around. Of course, you can factor in race, you can factor in zip codes, you can factor in ethnicity, you can factor in culture. These are all non-medical social determinants of health. However, they can be discussed under each of these components. So that's why you're not seeing things like culture, like race, like ethnicity, like redlining, like zip codes, and the likes of those things. They are valid, but they are not under the major categories. All right. So running down and brushing down. Excuse me, I've got cutters. So the first one, healthcare access and quality. The second one, economic stability. The third one, education access and quality. The fourth one, social and community context. And the last one, neighborhood and built environment. Now, someone might be saying, hey, Ruben, do you mean this is the order in which social determinants of health are categorized? No, please, there is no order. In this case, none of these components holds more value than the other. In contrary to that, all of these components needs to interact to actually produce health at the highest outcome. For you to enjoy health at the highest outcome, all of these components must interact together. They just have to. So if you look at the picture in this slide, you see the determinant of health in the middle, and of course, all of the components revolving around it. Each and every single one of these components revolving around it. So that means to tell you, none of these components ranks higher in value than any other one. We can make a case for each and every one of these to be the most important. So say with me again, healthcare access and quality, economic stability, education access and quality, social and community context, and of course, the last one, neighborhood and built environment. All right, let's roll. Social and community context. So, every time we talk about a social and community context or component in public health, one of the first things that should raise to your mind is diversity. One of the key things in public health, and that as public health professionals, you need to understand before you can make a difference, is to understand the level of diversity in the community you are working. Now, that diversity is what produces cultural differences. That diversity is what builds up cultural competence. That diversity is what makes you to think about cultural sensitivity. That diversity is what brings about cultural humility. So one of the things that all the time should come to your mind as a public health professional or as a chess person is, what is the level of diversity in this target community or target population? So again, under the social and community context, the first one we have is the differences in vulnerability. And Ruben, what does that mean? It means that you have a group of people, African American, the Hispanics, the Latinos, the Asians, all right? The, am I leaving out any other person? The H-Monk people, all right? You must understand what are they vulnerable to. As a matter of fact, we found out that breast cancer kills more African American people than the average white person. All right. We've also found out that myeloma as a form of cancer kills more African American people, all right, as compared to the white folks. However, there is data to support the fact that the Hispanics, they are on the receiving end of all kinds of diabetes. So what is it that the community is vulnerable to? And how does the social and community factor can aid that? How do we support these different vulnerabilities? How do we support the people that are vulnerable to these things so we can limit the impact, the negative impact of that disease on them? So when we talk about the social and community context, it means that socially, what can we do to support a community of people in what they are vulnerable in? And a good example is this. There is an organization in Fresno that is called West Fresno Family Resource Center, and I'm just giving a shout out to them right now. They've been a good partner to my organization. So an organization like West Fresno is a community-based organization. Everything they do is non-medical. And how do they do this? How do they factor into this SDOH? They basically organize events, organize cancer outreach programs, invite professionals to educate the Black community because they are more vulnerable. So that is a non-medical approach, giving equal opportunity to vulnerable communities. So what is the difference in exposure? That builds up the social and community context. Difference in exposure, that will also lead us to talk about what is the difference in the dosage level. So for example, if you are in a community, for example, if you live in Fresno, and I'm going to reference Fresno because I've done a few research work, written a few research paper, published a few articles on things happening in Fresno, okay? So, for example, in Fresno, the air quality is poor. It's abysmal. Fresno probably has the worst air quality in California, and I'm not even exaggerating. The numbers are there to support that. So in the social and community context, how do you prevent this from happening socially without doing anything medically? Policies, advocacy, that is the way to go. They are non-medical, they are non-clinical, but they can affect what is happening down there. What are the differences in consequences? Okay, people's interaction with family, co-workers, and community members. And of course, what does a social support circle looks like? So every time we talk about the social and community context, it means what is your interaction with the people around you? What is the interaction you have with the community-based organizations in your vicinity? All right. What is a social support circle? What are the community needs that have been met? All right. So this is the social and community context. Of course, you can also have what is sometimes the civic participation, social cohesion, and of course, the engagement, the community engagement goes a long way. Because under the social and community context, it becomes easy for a community specialist or a community-based organization to understand what is your expressed need, what is your actual need, what is also your perceived need. All right, so it becomes easy if there is an interaction in the community. In fact, it begins to help the process of needs assessment. So we understand now what is your need, what is your actual need, what is your expressed need, and what is your perceived need. So that way, an intervention can be created, a program can be implemented just to, to help or to promote health in the area that is lacking. All right. So the next one is education access and quality. And while I was making up this PowerPoint, one of the things I said to myself, and of course, and I've been a very big advocate for, is this. Very simple. Education is crucial. There are no two ways about it. There are no two ways about it. The way education affects the health of a people, it's so distinctive. And we get to that in a minute. So you just have to get a basic education. You have to have some kind of health literacy for all of those things to make sense to you. I was a part of a focus group evaluation some months ago, and it will surprise you if I tell you this, that we had 20 people in the focus group. A good number of the participants didn't really know the basis of the risk factors for diabetes. This is not a knock on them. This is more of a knock on the society, on the system, than the individuals. Now, less education is linked to lower income. Lower income is linked to poorer health. And why is that? So, We live in a society that values education. There is always an edge, an upper edge for those with education compared to those without education. And why is that? Because with education comes a better job opportunity. With a better job opportunity comes a much more higher income. With a much more higher income, it means that you can afford the basic things, or you can probably afford a good insurance. Having access to a good insurance also means that you probably have access to the good healthcare system out there, healthcare services out there. So you can see the long list of interaction between having a good education, having a higher education, not just a good one. You can have a good high school education and not have probably, a much more higher degree compared to someone else. So the less education is linked to lower income. It reduces your accessibility to things like insurance, all right? Reduces your accessibility to actual information, because one of the things we advocate for in health promotion is health literacy, all right? And we are under the mandate to make everyone understand what we are saying. However, which that is the Plain Communication Act. That is what I'm referencing right now. So, which is applicable in the United States. People who have access to quality education tend to stay healthier. And why is that? It's just a known fact. The higher the education you have, the more exposure you have. Remember, under the social community context, we talked about exposure. What are you exposed to in terms of health content, in terms of accessibility to better health information? All right. So let me just give us an example. All right. I have a friend who knows so much about cars. All right. So it's not just going to go to market, to the dealership, and just pick up any car. Oh, give me that car, I'm taking it up. No, he's not going to do that. And I asked him once, why do you do this? He said, because I have a knowledge of what cars are. And that hit me. Why? Because without access to quality education, you necessarily don't know what you should have in terms of health or what you shouldn't have. All right? Everybody knows diabetes is bad. However, how many people know that, okay, you have diabetes and you're working on it, okay, you can test for your A1C level. That needs a certain level of exposure to have that information. And that is what education provides you. All right, so the relationship between SDOH and education relies on three major things, which we've talked about, but let's just mention them. Education attainment. What is the highest level of education that you have? Education quality, not just the highest level, but what was the standard at which you got that education? And of course, the last one is education and its connection to other SDOH. All right. So again, we talked about the first one, social and community context. How does education quality factor in here? First of all, let me give us a good example. For example, I mentioned myeloma, the cancer, and the way it affects African American community. I, as an MPH graduate, I have a first-hand information on what to look for, when to get tested, how many times to get tested. So I'm not going to fall into that social circle of individuals who are susceptible to myeloma in the African American community just because of my education. And that applies to a lot of people. So you can see how the connection builds up from one component of SDOH to another, all right? So, and that's that on education access and quality. The next one is neighborhood and built environment. And I'm gonna take a pause here and probably spend some 7 minutes here. The neighborhood and the built environment. Like the name suggests, neighborhood. Where do you live? That's the major question here. How is your environment built? All right, how is your environment built? What is the infrastructure in your environment? These are important things. So, and I'm going to be giving specific examples. I live in California, so I'm going to give some basic examples in California, right? So when we talk about built environment, we talk about infrastructure. And let me give this example. For example, there is a city in California called Oakland. If you live in Oakland, in your environment, and Oakland is a place where the houses are compact together, there is not enough space to actually build community infrastructures like parks for the elderly, like playing ground for children, and the likes of those things, compared to another place like San Ramon, another city in California. So how is your environment built? And that is one of the things that determines health. Because in a park, you could literally have a place for free exercise. What does exercise do to you, do to the elderly body? It helps a lot. It helps with their sleep pattern. It helps with their agility, also the buildup of strength in the old age. Neighborhood violence. I am sure in California, Oakland has the highest number of city violence. And that's a fact. Apologies to those who live in Oakland and they are watching right now. But this is the truth. So there is so much neighborhood violence in Oakland, which also means that the level of access, now that brings about segregation. There are people who will never want to live in Oakland, all right? And there are people who will just have to live in Oakland. It limits the level of access they have to health and infrastructures. And without these things, there is not going to be improvement in health. So for example, let's give an example. Why is you're not going to find a Johnson & Johnson company in Oakland. I don't think it's going to happen. Just because of the antecedents of violence, the way the place is built up, and those things. If you have a place like that in Oakland, what does that mean? It means job opportunities. It becomes a high-income environment, all right? That affects the level of healthcare services that come in. That affects the level of professionals in the health system that are there. So it also brings about a geographic barrier to health. And this is important. And I'm just going to say this. One of the things I believe so much is this, in the health industry and in the social circle. Your zip code says a lot about you. So if you go for an health interview, or if you are trying to actually, if you are trying to get an appointment online, and it depends on the kind of insurance you use, they literally ask you for your zip code. What does that mean? That may not mean much to someone who is not in the field. But someone in the field, what does that mean? That means that limits the level, or that limits the kind of health care that you get, the kind of professionals that you get. We can make an argument that you get better healthcare professionals in San Ramon than you get in Oakland. And what will be a result of that? Your zip code. And that's just the reality of things, actually. Your neighborhood determines the access you have to food and, of course, food security. This might not necessarily be a major factor because I've been mentioning Oakland in Oakland. No. All right. So there is food regulation policies and laws around there. It's getting better over the years. And I think that's an area that the health sector has not been affected as much. All right. Has not been affected as much. What has affected people much in terms of food is lifestyle, not necessarily what the community is doing in terms of that. It's more of a lifestyle problem, okay? So, redlining, systemic racism, and the impact of zip codes. Let me take on 2 minutes here. When we talk about systemic racism, we are not talking about someone saying, oh, we don't like Black people or we don't like the Hispanics. No, that's not what we're saying. We're talking about a racism that is embedded in the system that literally prevents a certain set of people from having access to a certain set of services. So it's not spoken about, it's not being shown to you. The system directly or indirectly has just allowed it. It's just a part of the system now. And what can you do about it? Advocacy. Impact of zip codes, we talked about that. All this limits what you can get. And let me just say this, all right? Let me say this. Community lanes and parks. So for example, in a place like Oakland where there is gun violence, most times, it becomes nearly impossible to go ahead and build a standard community parking or a community environment there. It seems impossible. Economically, it's not advisable. Financially, it's not prudent. Knowing what the outcome might be, knowing the kind of environment that is, it limits the things they have access to. It limits the things that comes into that community. And that is why we always advocate no to violence so that our communities can be developed and we can have access to these things that ultimately improves the well-being of everyone. That improves the well-being of everyone, okay? That improves the well-being of everyone. Also, crime and violence, the quality of housing, that speaks volume to our people, the outcome of people, all right? Overpopulation determines the outcome of people. Crime, violence rate absolutely determines the health balance of people. In a community, in a built environment where there's so much violence, you begin to have segregation. Segregation now limits the things, the opportunities, and the interventions that can actually be conducted in your environment. As an health education specialist, if I'm given two options, hey, Ruben, do you want to conduct an intervention in Oakland and San Ramon or San Ramon? The first place you want to pick is San Ramon. However, you must factor in health equity, which might probably send you to Oakland. But that's just the reality of things. All right. Next one is economic stability. Okay, how does economic stability affect the health of people? Let me give a ground example. Like I said before, I come from Africa, proudly Nigerian, and it's a developing country that is in parts ravaged by poverty, right? It's a low-income nation. The jobs are not appealing. There is low infrastructure. Even though people are highly educated, it's a country that is ranked among the people that are most educated in the world. Okay, that's a positive. However, there is enormous inflation, there is massive economic instability, and there is unfathomable unemployment rate. So what does that do? It means that, for example, you cannot pay for your healthcare services. Not a country that dwells so much on insurance. Most of the healthcare services in Nigeria and in most parts of Africa are paid for out of pocket. So that means that if you do not actually have the actual cash or actual money in your account, you cannot go to the hospital. That is a direct link on how economic instability affects or is a social determinant of health. It determines the kind of hospitals you can go to. We've seen people with fractured bones and broken legs. They don't go to normal hospitals where I'm from. They go to, we call them traditional health workers. Less standard, less quality, more complications than healing. That's what you get. And someone who is watching this from outside the United States might be saying, oh, there is housing instability. Yeah, there are so many homeless people in the United States. And one of those factors is economic instability. So think about this. You have a housing problem, which means that you live on the street in the winter season, which means that technically this social determinant of health is exposing you to a disease such as pneumonia. During the COVID season, a majority, 15% of those that had COVID and didn't get vaccinated on time were the people who had housing issues and the homeless population. So directly, it influences their health. Their health is automatically not the same as someone who lives in a house, who lives under a roof. That is different. All right, that is different. The exposure level now becomes different. And this brings in the neighborhood and the social factor again. You can begin to see the interaction between these components and how they determine the health of people. And of course, poverty, like any other thing, not just determining the health of people, poverty determines so many things. Determines the level of education that our children get, determines the kind of education you have, determines the kind of hospital you have access to, determines the kind of medical services you are privileged to, determines a whole lot of things. So for example, you want to get kidney transplant, all right? How economically buoyant you are is going to go a long way into determining that. So that's a lot of connection we are able to make right there. So moving to the last one, health quality and access. And why do I have this last? This has been designed to come last because the first 5 factors or the first 4 factors will directly influence the health quality of an individual and of a community. Access to high quality and standardized care is determined by all of these factors. Are you economically stable? What is your neighborhood and built environment privileges? What is your social circle? What does it look like? All right. What is education? It's going to affect the access that you have. All right. Culturally and linguistically appropriate health education and promotion methods. Health quality and access. So, what is your cultural inclination? All right. What is your health literacy level? That automatically determines the health education and promotion methods that is being used for an intervention that you participate in. That is extremely important. And I keep giving this example, which is one of my biggest examples so far. Okay. A few months ago, I took an adult class somewhere. I got to this adult class session. The slides I had prepared and the literacy level of the attendees that I was expecting changed drastically. It meant that on the spot, just 10 minutes before that class, I had to change the materials. Why? Because of the health literacy level. That at that point determined the kind of health information they had access to. I couldn't go to the full length of health education I wanted to. So that automatically limited what they were getting in terms of quality. Cultural sensitivity, cultural humility. There is also class standard. So if you are watching this as a professional, I want you to go out and check out class standard. I'm going to put it in the bracket here so you can see that, all right? Class standard, all right? You can check that out and learn a few things. Understanding healthcare laws and policies. That is also important in how your health quality and you have access to. You just have to understand. You just have to, okay? You just have to. Okay? What are the health laws? What are the health policies? And the biggest one I think here is on insurance. What are the health laws? What are the policies on insurance? That is important to understand. That is important to know. That is important to know. You want to be up to date on the health information. And how can you really do this? Because you may not be privileged to know where to find this information. Even as healthcare professionals, we still struggle sometimes to where to find the appropriate context, the appropriate data, and the numbers. So what do you have to do? Talk to your healthcare professionals. Talk to your local health agencies. That is important to mention. Of course, we've made so much fuss about health insurance availability in this, all right? Is it Medicaid, Medicare? To your biggest surprise, you will still understand that about 20% of the American population do not have health insurance. About 20% of the people as of 2019 living in the United States do not have health insurance. Just look at that number and look at the number of people that are limited in access to healthcare services. Just think about that for a minute. Think about that for a minute. The United States is 3 times the population of Canada. Take out 20%, then you know the number of people who are absolutely at the disadvantage, at the receiving end of not having health services rendered to them. That says a lot. And that is a function of health education. That is a function of health education. So, and the last one is accessibility to services. Do you have access to services? Because in economic terms and in business terms, it's about demand and supply. If you can demand for health services and you know what to do, what processes leads up to getting that service, then it can be delivered unto you. You can have access to it. However, you must understand, how do I have access to these services? How do I have access to these services? All right. So quickly, I want to make a quick note on social and community context, and that is this. Your social and community context also has to do with the group of people that you interact with. So we're talking about the influences of this component on health, right? So your social and community circle determines it's basically the people there. The people there influences you on what to do. So influence of people is a great one. And we normally talk about health belief model. We talk about social cognitive theory. We talk about ecological models in health. This is where they come in. You have a group of people who are smokers, and these are the people in your circle. So it means that we are technically looking at a behavioral change. A behavioral change is definitely going to impact your health. That is another point to make right there. We can go back and forth on some of these things. A behavioral change impacts your health, and that is only going to come based on the social circle that you keep. That is important. That is important. All right. So we've talked about education, access, and quality. We've talked about neighborhood and built environment. We've also talked about economic stability and, of course, healthcare quality and access. All right. Healthcare quality and access. So once again, one of the questions you can see in the chess exam, generally speaking, I have not put out any question, is this. The question might be asking you in terms of finances. If the financial capability of someone is not enough or something, what component of social determinant of health is affected? You will know that is economic stability. All right. If we talk about social circle, the people and the influences around you, the behavioral aspect, that becomes a social and community context. And of course, one of the most important things I love so much is what I call accultural, am I mistaken? Acculturatization. All right. It means that how do you easily adapt to the culture of the people around you? How do you quickly fit into the culture of the people around you or in the environment that you live? Acculturatization, that determines the level of health. And let me put this out there. Japanese people according to data, they are some of the people who are easily acclaimed to culture. They are easily affected by the disease happening in the new place they go to, in the places they are just culturally getting used to, all right? Happens the most with them. So, conclusion and recommendations. Health differences are caused by decision-making process, policies, and social norms, which exist at all levels, all right? Health differences happens through a decision process. You decide the people who are in your social circle. You can actually determine what your level of education is going to be, all right, which will determine what your economic stability might be in part, and of course, the neighborhood you live, policies and social norms. Inequities in health are socially determined, preventing poorer populations from moving up in the society. We've pointed it out. Equitable health access is not enough. Intersystemic collaborations and partnership is the way forward. And I'm going to speak on this for about 2 minutes. I know we advocate for equitable health access, health equity, and that is good. I think that is one of the way forward for everyone to actually access health at the same level. However, we must begin to look at inter-agency collaborations. We just have to. We have to look for funding out there. We have to look for partnerships. We have to look for community-level collaborations. These are some of the things that will help grow neighborhood, that will help build infrastructures, that will help fund health systems, and that will definitely help bring the right professionals into the system, collaborations and partnerships. So the expansion of health status beyond disease trend and patterns. And of course, this is the most important part that we need to understand about SDOH. SDOH look beyond diseases. If you notice all day throughout the presentation, I've made very little references to diseases because it is non-medical. SDOH is non-medical. And so if you are listening from somewhere from Africa, from Nigeria, and I know we have a few outsiders from the United States, all right? SDOH is something you must advocate for. I know the disease pattern, the disease data, they are glaring and they are screaming at us. However, you must also understand that the components of SDOH are the things contributing to the level of the diseases in the society. If we can take care of the SDOH components, then we can ultimately reduce the level of diseases in the community. That is something we have to look at. And finally, health governing bodies must provide and ensure compliance with the indicators of health and equity. So not just the provision of the indicators, they must also ensure that, from nation to nation, like in World Health Organizations, the countries that are in there must go and must comply with the indicators of health equity that has been given to them, just to ensure that the standard of health from one nation to other is moving at least to being the same. In my opinion, the standard of health from one nation to another is never going to be the same. However, the bridge in health inequity can be closed a little. And I believe that as public health professionals, the onus is on us, the work is on us to advocate for these things, to put out, to create the awareness about these social determinants of health, and make it work, So once again, thank you so much for watching and sharing. Love you all, and see you on the very next episode. Thank you.